Okay. Hi, everyone. I'm Lynn Hernandez with the Desmoid Tumor Research Foundation. It's great to be here with you today. Thank you so much for joining us as we've just launched Desmoid Tumor Awareness Month with the patient community. Before we get started, we'd like to acknowledge and thank our Awareness Month virtual event sponsor, Recursion, for their support and commitment to education. We welcome you to our first live event this September entitled Biomarkers, Predicting Tumor Behavior and Choosing Therapies. Today we'll cover what biomarkers are, how they can be used, biomarkers for diagnosis of desmoid tumors, and some that have been proposed for use to determine treatment options. We're honored to have with us today Dr. Dale Shepard, Director of the Taussig Phase 1 and Sarcoma Programs at Cleveland Clinic. Dr. Shepard oversees early development of new cancer therapies, including the genomic-based treatments and immunotherapies. He sees nearly 200 sarcoma consults annually with patients from across the country, including patients with desmoid tumors. As a medical oncologist and clinical researcher, he has been the principal investigator for dozens of clinical trials and has been a recipient of the National Cancer Institute Cancer Clinical Investigator Team Leadership Award. Dr. Shepard is a thought leader for management of sarcoma, gastrointestinal, and genitourinary cancers, and has been a consultant for many pharmaceutical companies. He earned a PhD in pharmacology and his MD at The Ohio State University. He completed a clinical pharmacology fellowship at the University of Chicago. Most notably, though, Dr. Shepard sits on the DTRF Medical Advisory Board. During this webinar, we invite the community to post any questions in the Q&A. In the interest of time, Dr. Shepard will hold off on answering questions until the end of his presentation. The chat function will not be monitored for questions during this session. Dr. Shepard, we are so grateful to have you with us. Welcome, and I will turn it over to you.
All right. Well, thank you, Len. It's a pleasure to be here to talk about biomarkers and desmoid tumors. It's a very important topic, and hopefully over the next few minutes we can talk about what biomarkers are, how they might be utilized in the management of patients with desmoid tumors. So, without further ado. All right, so let's start off really high level. So if we're going to talk about biomarkers and how they can be used to manage patients with desmoid tumors, first thing, I think it really we need to go back and say, well, what is a biomarker? How do we define a biomarker? So when we think about a biomarker, it's something that could be measured in blood, urine, tissues, from a biopsy, and it's a measurable indicator of the state of disease. So, and we'll talk a little bit about those settings, but can use it for diagnosing whether a disease is present. Can you look and see if you can predict progression or a treatment response rather? So, something measurable. It's instead of not really having a good way of doing an estimation of disease activity. It's something that we can get a number and compare from over time, for instance. And so this can be used to determine something that's normal or a pathologic process or a response to therapy. So we don't use biomarkers simply only in a setting to look at diseases. Sometimes we use those to measure things that are normal as well. And there are things that one might think, if you go to your doctor and you have a physical, they might measure things, tests that look at your cardiovascular health based on, lipid profiles and things. That's not really directly telling you about what's going on in your heart, but it gives you an idea. So that's just a kind of a clinical example that you might think about. So how are biomarkers used? Well, you hear a lot of terms being thrown around, so I think it's worth considering what these might mean. So what is a predictive biomarker? And so a predictive biomarker, for instance, might be, is there something that can be measured that tells us how likely there is to be a response to treatment? So is there a setting where by doing a blood test, looking at the tumor tissue, we can determine whether it's likely a treatment will work? And, if you look in cancers, maybe something as a predictive biomarker might be, is there a particular protein on the cell surface? If that protein is present, well, then maybe a therapy might work. But if it's not present, then it probably isn't. There are prognostic biomarkers. And so prognosis or prognostic biomarkers really giving you an idea of the likely course of a disease. So can we tell whether someone has an aggressive disease that's likely to be life-threatening, or do they have a version of a disease that is relatively indolent? So it can give you an idea of expectations in terms of the course of that disease. So that would be a prognostic biomarker. And then there's diagnostic biomarkers. And that can sometimes, when we think about tumors and how we look at tumors and diagnose things, there's a number of ways we do that. And one is just looking under a microscope and say, what does it look like? But then sometimes we have to dig a little deeper. Is there a protein on the cell surface? Is there a DNA abnormality in the cell that will help drive to a particular diagnosis? You may start based on observation. There's 8 things it could be, but by using diagnostic biomarkers, you can determine exactly what that might be. So we think about what is ideal for a biomarker. What would make a good biomarker? Well, it has to be specific to the disease you're measuring. So if you have a positive biomarker, then you'd like to say, well, that means that you're likely to have that disease. It has to be safe and easy to measure. So is it a blood test that can be run simply? You don't want to have invasive procedures as a biomarker. It has to be something that's pretty easy and safe. It has to be rapid. You have to be able to act on the information. They aren't as useful if you have to get at some test that takes 3 months to come back. That's not going to be a good biomarker. There are people who have proposed for cancers, for instance, that if I take a piece of tissue and I send it to the lab and I grow it in culture, and then I look and see what kinds of therapies work, and then I can know exactly what therapy you need. You're like, well, but wait a minute, it's going to take three months or more to know that, and I want therapy now. And so it has to be rapid. If you're going to do biomarkers as a way to determine what kind of treatment, and then they have to be accurate and inexpensive. And then it has to be consistent for different populations. If we're looking particularly at genomic or DNA related things, you want to make sure that it doesn't work in only one patient population. You want to make sure it works for patients from other countries and cultures and ethnic groups. And so it has to be sort of widely applicable. Well, why not use a biomarker? What would be things? So if it's exceedingly costly, that would be something that you would want to avoid, because we're using it to maybe predict whether a treatment might work. And if the test itself costs enough, then perhaps it makes sense just to try the therapy and see if it works. Sometimes there's a lack of specificity. I see this sometimes in patients who come in with a cancer, and people will measure a whole range of blood tests that might tend to be elevated in particular cancers, but there's other reasons why they could be elevated. An example would be, there's a blood test, something called CA19-9. It's a marker, an antigen that shows up in the blood, and it oftentimes is elevated in people with pancreatic cancer, but simply having inflammation in your abdomen can cause it to be elevated. So you wouldn't want to be thrown off and say, well, I know I'm going to do a CA19-9, and then I'm going to know if this patient has pancreatic cancer, because they might, but it could be from something else. And then sometimes these biomarkers, particularly prognostic biomarkers, can cause a fair amount of anxiety. So people will get a marker, and then there's this thought, well, oh my gosh, people with this particular biomarker being elevated, they have a bad prognosis. Well, these are things that test populations. These are not things that necessarily test individuals. And so what if the patient who's really anxious because they have an elevated biomarker has a tremendous response to therapy. They might be one of the people that has a really good response and a good prognosis in a group of factors that might predict poor prognosis. So sometimes these biomarkers can cause sort of undue anxiety. So if we think about biomarkers, well, let's turn to desmoid tumors. If we think about biomarkers that could be important for diagnosis in that very early stage, and most of the time when we're talking the rest of this presentation, we're going to be talking about more things related to predicting recurrence and things like that. But from a diagnostic standpoint, beta-catenin we know is an important factor in terms of driving growth of desmoid tumor cells. And so there are signaling pathways that when they are abnormal, there leads to an abnormal accumulation of beta-catenin in the cell, in the nucleus, and that drives tumor growth. And so when we think about a diagnostic biomarker, there really aren't other conditions when the pathologist is looking under the microscope and says, I think this is a desmoid tumor. If they do immunohistochemistry, IHC, immunohistochemistry, and they find the cell has the right appearance, it's the right clinical scenario, and it has an elevated beta-catenin, then that's a strong indicator that there may be a desmoid tumor. APC gene mutations, these are determined by genomic testing, by PCR. Patients with FAP have an abnormal APC gene, and that drives the production or the formation rather of desmoid tumors. And so determining whether there's an APC gene mutation is important. Similarly, of the 85 to 90% of people that have a sporadic desmoid tumor, CTNNB1 gene mutations are most common. And so when the pathologist makes that diagnosis, it's important that they look for gene mutations in the tumor. They can do that again by PCR, for instance, because that's an important factor in terms of really further prognosis and other things that need to happen. I'll talk about that here in the next slide. There's a signaling pathway called Notch pathway. There are some Notch-related molecules, one called HES and one called ATOM. These are also thought to be sometimes elevated in patients that have desmoid tumors and the desmoid tumors themselves. And so by analyzing the tissue, it can help solidify a diagnosis. So these are some potential biomarkers that can be used to differentiate a desmoid tumor from other types of tumors. So I mentioned before about FAP-associated or sporadic desmoid tumors. So FAP-associated desmoid tumors have a mutation in the APC gene. And so there's a particular gene called APC. When that's mutated, there's a number of things that happen that are related to this generalized condition, familial adenopolyposis. There's patients with sporadic desmoid tumors, the mutations are in CTNNB1. It's important because the mutations can be determined by either looking at the tumor. And so when our pathologists look at when they look at the slides, they look and they make a diagnosis of a desmoid tumor, they look for those gene mutations so they can tell us sporadic versus FAP associated. Patients that have an APC mutation, they may not have any idea previously that they had FAP, that they had familial adenopolyposis. And if they find a desmoid tumor with an APC mutation, that suggests they really need to see a genetic counselor. They need to get a colonoscopy. There's other workup that needs to be done to determine the risk for colon cancers and other medical problems that are associated with FAP. So that testing with a biomarker, APC gene or CTNN1B, is really important at the time of diagnosis. At this point, after the diagnosis, with the therapies we have available, either surgery, systemic therapies, because of the common pathway that leads to this accumulation of beta-catenin, there's not a specific difference between FAP-associated or sporadic desmoid tumors in terms of treatment choices, particularly from a systemic therapy standpoint. So our tyrosine kinase inhibitors, sorafenib, pazopanib, nirogacestat is the gamma secretase inhibitor. We don't differentiate which one might be started first, which one's more likely to work based on presence of an APC gene or a CTNNB1 gene mutation. So it's really important for prognosis of the patient, assessing other medical conditions, but it doesn't play a role right now from the standpoint of treatment selection. If you think about biomarkers in general with desmoid tumors, if you pull up the National Comprehensive Cancer Network guidelines, there are new desmoid tumor working group guidelines. There's a new set of guidelines from really like a global consensus guidelines. Those were just published about 6 or 8 weeks ago. If you were to look and you look to see, was there a particular biomarker that's recommended from a diagnosis standpoint, from a treatment standpoint, they don't specifically cover biomarkers. I think that's exactly why, conversations like this about what we know and what we don't know, and what we are hoping to obtain in terms of information, and what we sort of our limitations. That's why things like this are important, because these questions come up, and it's important to kind of know what we know and what we don't know, and how we can use them and how we can't. And so the desmoid tumor working group does suggest that, and we'll talk about these as individual biomarkers. They do suggest that circulating tumor DNA is under evaluation and may be a potential biomarker for response or progression of disease. So that's, again, it's something that we'll talk about what the limitations of that are, but that is something that at least has been mentioned in the guidelines. So if we think about examples of biomarkers that we can use for treatment decisions, circulating tumor cells is one that has had a fair amount of work. And then the mutations, particularly in patients with sporadic desmoids, the CTNNB1 mutations, really probably have more data than any of the others. I'll list some of the others, we'll talk about them, but these are the ones that probably have the most data at this point. If you think about circulating tumor cells, it's exactly what the name implies. These are tumor cells that are identified in blood. You take a blood sample, and through that blood sample, you look and you see whether you can find tumor cells. Now, in some cancers, or in some cancers that I treat, so I have colleagues that are treating breast cancer, that are treating prostate cancer. There have been studies that suggest that in those particular cancers, we know that the level of circulating tumor cells can suggest prognosis, they can suggest response to therapies. But what we're looking for here is, can we understand whether the presence of a circulating tumor cell matters, for lack of a better way to put it, in patients with desmoid tumors? We'll talk about that here in a second. So this is where they were just looking to say, well, we know this is important for some types of tumors. Is it important for desmoid tumors? And so this was just a small evaluation of 18 patients. The patients themselves, males, females, not surprisingly more females than males. Tumors were in all locations, so it didn't differentiate sort of a location of tumors. It was extremities, it was abdominal wall, it was in the abdomen, the retroperitoneum. And they found that 100% of the patients, all 18 patients, they were able to find tumor cells that were in the bloodstream in an 8 ml sample of blood. So a simple vial of blood, they were able to identify tumor cells. They looked at the tumor cells themselves, and it looked like, based on the characteristics of those cells, that it was very consistent with what the original tumor looked like. Now, the question that comes to mind is what exactly the role of these are. So, really we know that they exist, but the question is, how do we use it and what do they even mean? And so oftentimes with biomarkers, we like to have some sort of ability to say, well, biologically, this makes sense. But we know that desmoid tumors don't metastasize. We think this is a mechanism by which tumors for a cancer, if I have a patient with a colon cancer, if tumor cells get into the bloodstream, then they deposit in the liver, they deposit in the lung. People develop metastatic disease. But since desmoid tumors don't metastasize, it's not entirely clear why they're there. And so there is a theory that maybe tumors somehow get reseeded by these cells, but I think the right answer is sometimes the right answer, and that is I don't know. I think that this is an area where we try to look and see how this might be able to be used. It's consistently present, but how do we use it to make predictions? That's going to be the key. Let's think about the gene abnormalities. So mutations in CTNNB1. And again, this leads these mutations lead to accumulation of beta-catenin in the nucleus. This drives tumor cell growth. This through something called transcription factors. We know that desmoid tumors, the mutations are primarily in one exon, exon 3. Exons, if you remember back to your biology classes, exons are the part of DNA that express, the DNA is what is expressed as proteins, and codons are kind of the sections within the exon that carry that genetic information. As it turns out, desmoid tumors, the mutations, even though it's a big gene, it's a big chromosome, that the mutations tend to occur in 2 of those exons. So about 35% of the time, there is a particular abnormality. It's a threonine at position 41 that's an alanine. 55%, there's an amino acid called serine it's substituted for one called phenylalanine. And then there's a serine to proline that occurs in a number. So these are the 3. If you do gene testing of desmoid tumors, these are the 3 mutations you're most likely to find. And so since we have 3 kind of unique things that are different in a gene that we know drives tumor growth, how can we use that as a biomarker? And so what we find is that really this CTNNB1 mutations drive a lot of different things. It drives proliferation of cells. It can affect angiogenesis or formation of new blood vessels. It can affect something called apoptosis. It actually inhibits that. Apoptosis is something where cells will sort of die on their own. It's a spontaneous death. Something called autophagy is where cells sort of take on the ability to sort of self-destruct again as well. And it also affects immune escape. So these are all things that are very, very important for either growth of tumor or continued presence of tumor. And so the tumor doesn't spontaneously go away. Now, we do know that desmoid tumors can spontaneously grow, of course, but we also know that 20 to 30% of the time that desmoid tumors can shrink, and really for no apparent reason. So these biomarkers could be important to understand which patients have tumors that are going to grow, and also which tumors are likely to spontaneously regress. If we could pick patients that we know they're going to have tumor get smaller on their own, then we don't have to worry about trying to treat them and give them a therapy to make that happen. And so this is kind of where we're looking to see how these biomarkers will affect. If you look at the biomarker field, the field of biomarkers in desmoid tumors, you'll find that there's been work going on with this for a really long time. This is something from Alex Lazar, that it's a pathology review from 2008. There's a lot of things that have happened a number of years ago. And this is looking at a wide range of tumors, different types, looking to say, well, after a tumor has been resected, how many patients and over what time period do patients have a recurrence of that tumor? So we know that recurrence can happen anywhere from 25 to 70% of the time. People can get a tumor that recurs, and that's why we don't jump to surgery anymore. What if we could predict which patients might have a recurrence and which ones might not? And what you find in this graph is that, again, if you look at the x-axis over a long period of time, either no mutation or having that T41A mutation, the patients that had the T41A mutation didn't really have any more risk than people that didn't have a CTNB1 mutation. But if you had that S45F mutation, you're much more likely to have a recurrence. So more people recurred and it happened faster. If you look at a number of those mutations, the three I mentioned, and sort of looking at recurrence and its sort of how it differs based on mutational status. So overall, if you looked at all comers, that first column, 25% of patients had a recurrence of tumor after resection. If you looked at patients that had an S45F mutation, 42% of those patients had a recurrence. T41B is about the same as the general population. And if you had that S45P or a wild type meaning no mutation, you're down to 14 and 17%. So based on the mutational status of CTNNB1, you might be able to predict how likely it is for a patient to have a recurrence. From a practical standpoint, if you have a patient that you're considering taking to surgery, if this was validated, and I'll go back to this, the question would be, are there patients that you'd be more comfortable doing surgery because of the mutational status and the likelihood this might come back? And I say that with caution because this hasn't really been prospectively shown to be true, but these are the kinds of questions that come up when we think about those mutations. This is another graph that kind of shows a very similar. This is actually from a very recent paper. I think it's within the last month or even this month that talks about mutations in CTNB1 and biomarkers and desmoid tumors. And similar to what we saw before, some mutations like the S45P mutation is really the same as not having a mutation. And the patients that had the green line is patients with that S45F mutation, and they are more likely to have a more rapid recurrence of their tumor. There are other factors, though, that of course this is not as straightforward as one might immediately think, because there are other factors that weigh in on whether tumors are likely to recur or not. And so if we look at gender, for instance, so this is looking at a population and saying, well, does it matter if you're male or female? And if you are a male and you have surgery to resect the desmoid tumor in this particular case series, you're more likely to have a recurrence if you're male. So genomics matter, gender matters, tumor size mattered. If it was a tumor that was over 6 centimeters, you're more likely to have that tumor recur. And so, this was a statistically significant finding. So, and then the other thing that we consider, which we've known for a while, is that the location of the tumor can matter as well. So if it's an abdominal wall, like in the wall of the abdomen itself, it is less likely to recur. And quite honestly, clinically, I am less worried about someone taking out a desmoid tumor surgically in the abdominal wall because they don't tend to come back as often. But if it's in an extremity or it's inside the abdomen, I get much more worried because we know that those are more likely to have a recurrence. Now, that being said, this suggests that there are a lot of factors in play. So really what we're going to find is that there's probably a model that can be developed that if in fact we find that S45F mutations play an important role in recurrence. And I showed you a couple of examples, but there are numerous examples. If you look in the literature, there are very few examples where that T41A mutation drives a significant recurrence risk. And there are not really examples, other than maybe some anecdotal examples of a significant difference with the S45P mutation. So that this S45F mutation seems to be the one that's most likely to be a player in terms of recurrence risk. Now, again, what we primarily talked about here is if you have surgery and it gets resected, how likely is it to come back? What we don't have as much information about is the impact on these genomic mutations on treatment effect, on how likely it is that if I have a tumor and I give a gamma secretase inhibitor, how likely is it that I have a complete response, a partial response, or no response? Like how do the mutational status affect treatment response, treatment duration, things like that, treatment, like the response duration, how durable a response is. So those are things that we're still somewhat missing. There's a number of things that are being tested and tested in a setting called active surveillance. That means, when we think about desmoid tumors, we're less likely to jump in and cut them out now. We're much more likely to be watching them and observing them. Can we use these mutations to know whether somebody can be observed or not, whether it's safe to do that? And can we use these mutations and measure them over time? And if we find a difference in the biomarker, that might trigger us to try to think about doing a treatment sooner. And a couple of examples, we talked about the cTNNB1 from a tumor and the mutations, and maybe give us an idea of how safe it might be or how likely it is to be monitored. Do we need to monitor more frequently? Do we get scans? Do we get a genomic mutation? And based on that mutation, if I have an aggressive mutation, for lack of a better way to put it, the S45F, do I scan every 3 months to look to see if things are growing? But if I have one that's less likely to lead to recurrence or tumor growth, like this T41A, do I scan every 6 months, right? So can I tailor my treatment in terms of observation based on these factors? So, cell-free DNA is essentially like circulating tumor cells, but I'm measuring DNA directly from a blood test. The tumors can essentially shed DNA into the bloodstream. I can measure that, and perhaps an increase in mutations. Do I see more mutations developing, or do I see more tumor cells that are developing mutations? Does that somehow affect my surveillance? And then there's also these sort of mRNA molecules that are important for transcription, for like production of proteins from DNA. And that's another blood test that's being tested. Again, I show these because these might become more active players, but at this point, still very much in the being studied phase. So we think about things to predict post-operative recurrence, and we talked about cTNNB1 and the mutations. There are a number of downstream proteins that can be looked at. Cyclin A and D, COX, which is cyclooxygenase, platelet-derived growth factor receptor. These are things that can be looked at in the tumor, and we think that we know that these are downstream of signaling pathways. So again, we have tumor cells. Those tumor cells have signaling mechanisms, something called Notch, something called Wnt. That's how our treatments work, by modifying those signaling pathways. But if those pathways are not working properly, then you get, much like a buildup of beta-catenin, you get a buildup of some of these things like cyclins and platelet-derived growth factor. These are things that are, again, very much in an experimental sort of setting at this point. But again, the question becomes, can we predict the best way to treat an individual patient based on some of these factors? And so things that we're not yet able to drive decisions on, but hopefully we will at some point, and so that we can get the right therapies to the right people. So one thing that comes to mind is, well, if we're thinking about biomarkers, like what are potential downsides? Like what can get you into trouble? And this is why I was careful when I said, I gave the example of like, well, if somebody happens to know they have an S45F mutation, do I think about surgery differently? Do I think about treating differently? I think the reality is these are all things that are going to be coming around. But right now, we don't have enough clinical evidence, prospective trials where we have a hypothesis that we test through a clinical trial to say yes. So I guess an example what I'm calling a downside of biomarkers. And I'm just going to give this as an example of where there have been cases where biomarkers have been used in a fairly routine sort of basis, but then you come and you look and you say, well, is that the right thing to be doing? So you got to be really careful when you measure things that you're actually measuring something that gives you a real change in how the patient's being managed. Are we truly helping patients by measuring it? There are diseases that I have treated. I really only see sarcoma now, but I've seen prostate in the past, and I've seen pancreas in the past, and neuroendocrine in the past. And there are markers for those diseases. There's PSA for prostate. There's CA-125 for colon. There's marked blood tests that can be measured, and it was standard therapy. It was standard, and actually still is in many cases, that women with ovarian cancer, there's a blood test, something called CA-125, that would be used to drive treatment decisions. And so patients would, I think I have a crawl, might be on your screen. All right. I think we're overloaded power-wise or something. I don't know. I got rid of it. Something popped up. So it was sort of routine that if you were seeing a patient and they came into your clinic, you measure a CA-125, and even if they clinically didn't really have symptoms, that sometimes drove changes in treatment. And so, and this is what, as much as we'd like to have a meaningful biomarker in desmoid tumors, we've got to make sure what we ask for, and that it's actually measuring the right thing at the right times and giving us the right answer. So this actually at ASCO, which is the biggest oncology meeting in the United States here, this was actually one of the plenary presentations about 10 years ago or so. Because what they did was they did a study, and I know this is a desmoid tumor talk, but I think it's informative in terms of how we think about markers. CA-125 was a well-established marker for disease activity in ovarian cancer. So this was randomization. So patients were broken into two groups. CA-125 was gathered in everyone, but only one group knew what their CA-125 was. And it was business as usual. The CA-125 goes up, they're likely to change therapies and make clinical decisions based on that CA-125. That's the early group. The late group, the investigators knew what the CA-125 was, but the treating doc and the patient did not. And so all of the decisions were made on good old-fashioned things like, how do you feel? Are you having new symptoms? Should that drive should drive imaging? If you actually have evidence, either clinically or with radiographic evidence that something has gotten worse, then you treat, right? So not relying on a number. I always tell people when they get fixated as numbers, I'm treating you. You're a person, you're not a number, right? So what ended up happening? So if you look at who got second line chemotherapy, so how many people had, like, when did they start the next line of chemotherapy? Well, the blue line is the early people. These are the people that knew what their CA-125 was. The number goes up, they flinch, they go, oh my gosh, I either have badness now or it's coming. And so they started chemotherapy. It was less than a month after that. So they first started that study, that number came back and they were off to some other therapy. So very, very rapid. And then if you look at the delayed group, it was a long time, almost 6 months before, as a median, for their getting that next line of chemotherapy. So much, much later to get started on that chemotherapy. If you look at quality of life, again, the delayed group is the red on top. They had a better quality of life. And so they weren't on chemo as often. They weren't switching therapies. There was less anxiety. I mentioned before about the problem with anxiety. And so patients felt better. Their global health score was better if they didn't know what that number was. And so one might say, well, okay, fine, but were they adversely affected? And the answer is no. This is the survival numbers. And so there was absolutely no difference in how likely they were to survive. And in fact, the delayed group, it wasn't statistically significant, but shaded toward longer survival. So less chemo in total, felt better, lived just as long as the people with all the extensive testing, and all of the changes in treatment. And so when it comes to biomarkers, you got to be careful what you ask for. You don't want to induce anxiety and needless sorts of procedures and changes when it doesn't really matter. And that's where we kind of are with the potential for desmoid tumors and biomarkers. We have candidates, right? We have things that we're looking into, CTNNB1 and mutations and the circulating tumor cells and a variety of downstream things that can be measured in the tumor cells or in blood. And there's potential questions that could be answered, but right now, these are things that we can measure, but we don't honestly know in a robust way what to do with them. And so I think there's great room for hope that we can answer some of those questions. Some of those questions might be, who needs to be treated initially? Again, surveillance is a really important part of managing desmoid tumors. And if you have a biomarker that you can reliably look at and say, you're fine, your tumor's not growing and it's not likely to grow, you have a lot more confidence in the ability to just do active surveillance and watch it. But you might have a biomarker that goes, you know what, you got to keep a closer eye on this, right? So who needs treated? How long to treat? This is desmoid tumor patients are often patients who are younger. They're trying to go about and live an ordinary life, and we're giving them treatments that might give them side effects. We're giving them treatments that can alter their ability perhaps to have children. We have, might impair their career development in terms of like their ability to get to work. How long do you have to treat? Do we have the ability to develop a biomarker that says, well, your tumor looks relatively stable and you have a biomarker that has gone down to the point where it's not likely to grow for a while? The prognosis question, how aggressive is my tumor? Is this something that I'm going to have rapid progression? It's going to be difficult to treat? Or is this something that's going to be relatively indolent? Will my tumor respond? So do I have a tumor that if I were to give treatment in general, is it likely to respond to therapies? Can we answer those questions? We know that, if you look at nirogacestat, I mean, an 8% complete response rate. Is there a marker we can ultimately come up with and say, well, you're one of the ones that are likely to have that complete response? So can we, first off, see if there's a response at all? But again, looking at one of those other bullets, is there a difference in the selection? So are some people more likely to respond to a certain type of therapy than others? Who's likely to have the recurrence? We talked about that briefly. So if there's somebody has an abdominal desmoid, which we know has a lower likelihood to recur, but they have an S45F mutation, should you not take it out? Right? So can we target who we do surgery and not do surgery on, for instance, based on likelihood for recurrence? You may find that if a patient has a T41A mutation in the CTNN1B1 gene, that the likelihood for recurrence is so low that it'd be ridiculous not to cut it out, right? So these are the sorts of things that we have the potential to answer. We have candidate biomarkers, but the bottom line is that these are all being studied right now, and we just don't have the robust data to use them for clinical decisions. But that doesn't mean there's not hope, because we have candidates, we have questions. Hopefully we can do the necessary trials. It's been established that the desmoid tumor community responds well to participating in trials. We have investigators who are robustly putting people on trials. These questions can be answered, and hopefully we can develop biomarkers that will make a difference. So I think this slide means that now it's your turn for questions.
Okay, this is great. Thank you so much, Dr. Shepard. This is wonderful. So I do have a couple questions here for you. Someone is asking, is there a way to determine how long an individual has had their tumor?
Yeah, this is a frequent question, and I normally have to give the same answer. So, certainly if people have had imaging in the past, And so, most people will have a sporadic desmoid tumor. It might be in an arm and a leg or someplace that they may well not have had any imaging previously. And so those are things where, people will come in and this may be their first imaging that identified it. And so my usual answer is generally, I have no idea because we don't have like a comparison image or film to look. It's really, oftentimes, the patients with FAP that are getting more observation, for instance, for surveillance for other conditions, they've already had some imaging, and then you might see something new, then you can kind of answer that question. But most of the sporadic desmoid tumors, we don't have much of an idea because we don't have the advantage of previous imaging. And there's not really a biomarker that gives us the how long.
Okay, got it, got it. Someone else is asking, would the tumor cell count matter during a blood test?
With the tumor cell count. So I think that like the number of cells, is that maybe the intent of the question?
Yeah, that's what it sounds like.
Yeah, so it's I think it's an interesting question because we don't, like, big picture, we don't know what that necessarily means. And it's back to that biologic correlate. Why are these cells even there in the first place? So as an example, for prostate cancer, patients, if you look at the number of circulating tumor cells in a metastatic setting, you start them on chemo, and then you look a few weeks later at the number of cells, you can predict how well they're going to respond, and you can make a lot of predictions on how well they're going to do based on whether it went from 5 cells to 3 cells, or the number of cells in that that sample. But it's a setting where we know they have metastatic disease that's like sort of shedding tumor cells, and it's sort of this thing, well, there's the tumor is getting treated and there's less cells. And so in this case, I think, quite honestly, the number of tumor cells in my mind is a little confusing because it's not even entirely clear why they're there. We know this doesn't metastasize. These don't deposit somewhere. And so I think one of the big questions is, why are they even there in the first place? And so right now we don't know necessarily what the number means. That small study that I had showed earlier from a while back had just established that all the patients had them, but they hadn't made the same sort of, like, what does it mean to have more or less, or have them change in number.
Okay, got it. Thank you. Let's see what else. Can circulating tumor cells be used to confirm diagnosis?
I don't think it'd be the most common thing that we would do because, typically we always like to see something under a microscope. There is a big move toward doing more what we call liquid biopsies. It's an interesting idea. So, a lot of these, my particular patient population tends to be really heavily shaded toward patients with FAP. And most of the time they have intra-abdominal desmoid tumors, which aren't as easy to biopsy. And so, it's an interesting question. So can you do a blood test initially and try to find desmoid tumor cells in the bloodstream instead of doing a more invasive biopsy? Certainly, it's not something that we do at this point, but it's an interesting question.
Okay, we have another question here. If there's a suspicion of a desmoid tumor and difficulty obtaining a biopsy due to tumor location, could biomarkers potentially be used to point toward a diagnosis?
Yeah, I think that last question is kind of along the same line. So if I was unable to establish that, just because of ease of getting to something, safety of getting something, desmoids in patients with FAP are oftentimes associated with a mesentery, which sort of supplies the nerves and blood vessels to the intestines. So sometimes access isn't the easiest without a fairly invasive procedure. So in that case, if circulating tumor cells or cell-free DNA ended up being a validated marker, then that could certainly ease in diagnosis. Probably if we think about extremity, something in the extremities, probably getting a biopsy is going to be quicker, easier than doing something like a blood test. You're going to have tissue actually in the needle. It goes right to pathology. With a blood test, you're going to be somewhat dependent on the sensitivity, whether you happen to have enough tumor cells. So it would be helpful if you did that blood test and you found tumor cells, but it wouldn't help you at all if you didn't, because it wouldn't rule out the fact that you had a desmoid tumor. That's where a biopsy of something in an extremity or an abdominal wall would probably be a better approach.
Okay, got it. Another question, is there evidence of how well the S45F mutation responds to sorafenib as a systemic therapy?
Yeah, so that's part of the, I mostly talked about things we can do to diagnose and things that really have, most of the work has been done looking at the likelihood for recurrence. We don't have great data on how a mutation drives response. We also don't have good data on if specific mutations help with this whole phenomenon of spontaneous regression. I mean, and I think you can't underestimate the importance of that spontaneous regression question. Actually, at the last advisory board meeting, there was a discussion about maybe taking that on as a research project, because much like if you understand what genetic, metabolic, whatever changes will cause the development of a tumor or the growth of a tumor, I think it could be equally enlightening if you find that there's a particular mechanism that causes a tumor to spontaneously get smaller. Well, that's another thing that you might be able to therapeutically, sort of harness and say, well, if I know how to trigger that mechanism, then I might be able to make tumors get smaller. So at this point, though, we don't have enough data that sort of subsets patients by treatment, by mutational status and treatment to make those connections.
Okay, let's see what else. Can you share about how biomarkers relate to cryoablation?
Yeah, so again, from a response standpoint, I don't think from a, if you think about cryoablation, you're putting a probe in a tumor, you're making an ice ball and killing tumor. I think from a sort of how well it works is probably not going to be a big difference from a biomarker standpoint, because you're just mechanically causing tumor to be mechanical destruction of tumor. So it's not going to be as much dependent on the biology of the cells themselves. I anticipate that the factors that lead to recurrence and the biomarkers that might predict recurrence from surgery would be very similar after cryoablation, because the problem with the desmoid tumors, they have these little tendricles that sort of, even if you surgically removed the tumor and you think you've gotten it all out and you have apparently negative margins, you still have that sort of tendricle effect, and that leads oftentimes to recurrence. Well, if you think about ablation, you're just forming sort of a sphere of ice and you're killing tumor, you probably still have that sort of remnant of tumor. And we know that even after cryoablation, that tumor cells can come back and tumors can regrow. And so I'm going to suspect that what we learn about recurrence and predicting recurrence risk with biomarkers after surgery will probably be very similar to cryoablation. So probably not so much on the treatment itself and who should be treated from a response standpoint, but probably similar on the recurrent side.
Okay. Do female pregnancy hormones cause desmoid tumor growth, and would biomarkers show on a newborn baby?
So I guess the first part of the question is that clearly there seems to be a relationship between estrogen levels and desmoid tumor, growth of desmoid tumors. We know women are more likely than men to get desmoid tumors. We know that I just had a patient I saw recently, and every pregnancy had been associated with development or growth of a desmoid. And so we know that there are absolutely hormonal factors. We know that things that block estrogen receptors, tamoxifen and raloxifene, there is some data for them as agents that can minimize growth. Sometimes those make it into the consensus for NCCN guidelines, and sometimes they don't. And so I think that that clearly there may be some way that, by looking at biomarkers related to estrogen levels and hormonal levels, there might be some way to predict who might be more or less sensitive. I think it's the estrogen itself, which of course could be considered a biomarker, is probably the biggest driver. The second part about the newborn, what was I don't want to leave it unanswered, but I'm trying to clarify what the.
Yes, hold on, let me get that. Would biomarkers show on the newborn baby?
I can't immediately think of what kind of biomarker might predict something that you'd find in the newborn, other than if you think about looking at gene abnormalities that might be present. That would, of course, would be APC gene. We don't typically test for APC gene abnormalities until a little bit later in life. The sporadic desmoid tumors with the CTNNB1 mutations, those are what we call somatic mutations. So those are not transmitted to children. So people with a spontaneous desmoid tumor do not pass those along. Patients that have APC mutations, that mutation does pass along in many cases. And so that might be able to be determined, but it would be much earlier than we would typically look for that.
Okay. And I think I had one other question, just time for one other question. For a desmoid tumor with a confirmed CTNNB1 mutation that has been treated successfully twice systemically, but unfortunately regrown again each time, is it possible that new mutations have occurred with each new regrowth? If so, is it worth repeating a biopsy of the tumor?
So I think the answer is we don't know as much about development of new mutations, but it's probably less likely than in some other kinds of tumor. So I see a lot of patients with GIST tumors, and they usually, if they are starting to grow on a therapy, they have oftentimes acquired another mutation. We have those three primary mutations in the CTNNB1, and I don't think we have good evidence for multiple mutations. It's usually a mutation. So, I think there's lots of factors that play into why these therapies work. I mean, it's a frustration with all these therapies that, there's a percentage of people that have a good response. There are patients that have relatively stable disease, and then there are patients whose tumor grow. And we don't know who's who from the onset. So it's probably factors other than acquired mutations. But I guess the only reason, I guess, from a very practical standpoint, not necessarily to retest for mutational status, is that we don't really have the data to know if I have this now, I have a different mutational status, and then that means I go to a different therapy, right? So at this point, we don't necessarily know that a particular mutation would align with changing to a different treatment or what that treatment might be. So that would be the only reason not to. I mean, academically, it's an interesting question. It would be interesting to know, but it wouldn't necessarily help us drive to that next therapy. There's still, unfortunately, a little bit of an empiric. Have to try and see if it works.
Okay, I think that's all the time that we have. Thank you so much, Dr. Shepard, for taking the time to speak with our community today. Just a quick note, each desmoid tumor case is different. These conversations are not intended as medical advice for any individual problem or as a diagnosis, treatment plan, or recommendation for a particular course of action, and should not be used as a substitute for professional medical advice and services. Thank you again to the Desmoid Tumor Awareness Month virtual event sponsor Recursion for their support and commitment to education. And of course, we'd like to thank the community for being with us this afternoon. After being formatted, this broadcast will live on Facebook and in our video library, actually not on Facebook, but in our video library. And it will also be on our website under dtrf.org/awareness. Thank you again to Dr. Shepard, and we wish everyone a wonderful evening. Thank you.
Thank you.
Bye-bye. Thanks so much, Dr. Shepard.
Well, thank you. Appreciate it.
This was really wonderful.